The microphone? Oh, okay, there we go. Well, good afternoon, everyone. I see it's 4:01, and I want to welcome everyone to our every other month meeting, or is it quarterly meeting? The way my talking points is written, it says bi-monthly, and I really have a problem with that term bi-monthly, because to me bi-monthly sounds like twice a month. I know colloquialism, it's like every other month and bi-month, but I don't agree with that. So I have to talk to Robin, who wrote this. She's probably listening. She has bronchitis. Yeah, you have a communications director who can't speak. That's, right. And she can't sign either, so that's a difficult thing for her. But welcome to our commission meeting of the Commission to Study Mental and Behavioral Health in Maryland. It's hosted here at the Smith Theater, located at the Howard Horowitz Visual and Performing Arts Center here at Howard Community College. This is our first community-based meeting since the COVID-19 pandemic that began in the United States in March of 2020. And we're going to keep with local guidance and rules here at Howard Community College, and masks should be worn at all times while indoors. Again, wear your mask while attending today's meeting. We're pleased to see that those who've joined us today in person, we're pleased to see a lot of people joining us in person and appreciate your cooperation. I want to thank Howard Community College and Dr. Kathleen Hetherington for hosting us today. I have a particular affinity for the college here. I talked to her about that a little later. My son went to school here. I had the opportunity to teach here. My father's ham radio equipment was donated here. And so I particularly, like I said, have an affinity here. The school's president, Dr. Hetherington, has dedicated her career to higher education and advancing the mission of community colleges and providing accessible, affordable education. And unfortunately, after 14 years as president here at HCC, she has decided to retire and will be leaving us in a couple of weeks. So before she does leave, I would like to present her with the governor's citation. I'm going to come over to thank her for her service. We didn't want to tell you this in advance.
This is such a nice surprise. Thank you so much.
So this is for you. I can read it, maybe for everyone else.
Yeah.
Dr. Kathleen Hetherington, greetings. Be it known that on behalf of the citizens of this state, in recognition of a well-deserved tribute to applaud your distinguished record of leadership, service, and achievement, dedicating your career to higher education and advancing the mission of community colleges, in honor of your outstanding contributions during your long and successful tenure as president of Howard Community College, and as our citizens join together in offering our grateful appreciation and sincere best wishes on the occasion of your retirement, we're pleased to confer upon you this governor's citation signed this day, Lawrence J. Hogan, Jr., Governor, myself, and John C. Wilton Smith, Secretary of State.
Thank you so much. I
Thank
appreciate
you.
it. Yeah. What a nice surprise.
Thank you.
Are you ready for my remarks now?
Yes.
Yeah, okay. Well, thank you so much, Lieutenant Governor Rutherford. I tell my staff I hate surprises, but I like surprises like this. So I really appreciate it. And good afternoon and welcome to Howard Community College. This meeting was originally scheduled to be in HCC in February of 2020. After the events of the past 18 months, I'm grateful that we can be together in person and virtually today. And thank you, Lieutenant Governor Rutherford, for leading the commission to study mental and behavioral health in Maryland and for recognizing the importance of these issues at such a critical time as now. And I also like to acknowledge, because it was in my notes and then not in my notes, but Mr. Secretary Dennis Schrader is with us today, and Mr. Schrader has a wonderful long history with the college. He was one of our trustees and served as vice chair, and did such a fantastic job that the governor stole you from us. So we're happy to see you and welcome home. And congratulations on the work that you've done. It's been phenomenal during this period of time and really, really tough. So appreciate that. The pandemic brought on so many challenges surrounding mental and behavioral health that shed light on numerous gaps in mental health care. This issue hits close to home at Howard Community College. Prior to the pandemic, the number one issue our students reported facing was anxiety and depression. Since then, the number of students seeking assistance for anxiety and depression through our counseling center has increased dramatically. I'm incredibly proud of Howard Community College's commitment to student mental health. When the world turned upside down in March of 2020, HCC quickly pivoted to provide the same high-quality mental health counseling services to our students virtually through telecounseling, similar to how many of us connected to our doctors via telemedicine. And just so you know, we never had done that before. This was a new frontier for us. So this method of connecting with our students at home, at times convenient to them, has continued, even as the college has returned to campus. It's critical that we make mental and behavioral health care accessible to all. I'm looking forward to the shared dialogue today, and thank you again, Lieutenant Governor Rutherford, for bringing this discussion to the college. And again, my thanks for this wonderful citation, and please convey my thanks to Governor Hogan as well. Thank you very much.
Again, thank you for all that you've done for the students here at Howard Community College and for our state in general. Okay, as we know, through data and anecdotally, mental health and substance use disorders are linked in ways that are complex and multi-layered. Studies of the past 15 years have found that those with substance use disorders have a higher presence of suicidal thoughts, suicide attempts, than those without. And those who had attempted suicide are more likely than others to have underlying substance use and mental health disorders. The data-informed overdose risk mitigation, or DORM, program is a project led by our Opioid Operations Command Center and the Maryland Department of Health's Behavioral Health Administration. DORM aims to use data from victims of fatal overdoses to identify risk factors for death from overdose and better coordinate public health responses and interventions for those with substance use and behavioral health disorders. So far, the analysis has found individuals who've received outpatient mental health services in our public behavioral health system within 30 days before their death were more likely to have received both mental health and substance use disorder services. However, I want to stress that there's still very much that we do not know about the link between substance use disorder and suicide, and there is not one single cause why someone would take their own life. Today, we have board members from the American Foundation for Suicide Prevention, Maryland chapter, joining us today. AFSP connects those at risk for suicide and those who care about them with suicide prevention resources. This organization also connects those who have lost loved ones with additional resources and support. There will be Out of the Darkness walks planned throughout the state this month, and as well as into next month. On September 18th, they will hold an Annapolis Out of the Darkness walk at the Navy Memorial or Navy Marine Corps Stadium. On October 23rd, the walk will be here in Howard County at the Inner Arbor Trust on Little Patuxent Parkway. There will be staggered arrivals at both events due to COVID-19 concerns. You can find more information about AFSP and Out of the Darkness walks across the state by visiting their website, AF, and I think are there dashes in between, afsp.org/chapter/Maryland. I would like to also present a proclamation in recognition of Suicide Prevention Awareness Month, which is this month, and the work that they're doing. And I think I have the proclamations over there, so let me go over there and read that. I forgot how long the office was. Originally, it was at my chair there, but the proclamation for National Suicide Prevention Month, whereas suicide remains the 10th leading cause of death in the United States and the second leading cause of death among individuals between the ages of 10 and 34. Oh, please come on up. Thank you all for being here, and good to see you again. I just have to say, the last time I saw her, we were walking in one of the parks, and I came home with ticks.
Oh, no. I'm so sorry.
Well,
It's not my fault.
No, it wasn't your fault. No, because we selected the place. Hi, Courtney. Whereas in the United States, more than 47,000 people died by suicide in 2019, according to the Centers for Disease Control. And whereas suicide rates have increased 30% over the last 2 decades, with suicide rates finally decreasing 2.1% between 2018 and 19. It is estimated that in 2019, there were 1.38 million suicide attempts. And whereas in 2019, suicide was the 11th leading cause of death in Maryland, 657 people died by suicide in Maryland during 2019. And whereas more than 90% of the people who died by suicide have a diagnosable or treatable mental health condition, although often that condition is not recognized or treated. And organizations such as the American Foundation for Suicide Prevention are dedicated to saving lives and bring hope to those affected by suicide through research, education, advocacy, and resources for those who have lost someone to suicide or who struggle, and urge that we recognize suicide as a preventable national and state public health problem and declare suicide prevention a priority, to acknowledge that no single suicide prevention program or effort will be appropriate for all populations or communities, address the disparity in access to mental health care for underrepresented groups, and advocate for ending disparities, fund new suicide research to support culturally informed and evidence-based mental health care and service, encourage initiatives based on goals contained in the National Strategy for Suicide Prevention and the 2020 Maryland Suicide Prevention Plan, promote awareness that there is no single cause for suicide, and that suicide most often occurs when stressors exceed coping abilities of someone struggling with mental health conditions, and develop and implement strategies to improve and increase access to quality mental health, substance abuse, and suicide prevention services and programs. And therefore, I, Lawrence J. Hogan Jr., Governor, State of Maryland, do hereby proclaim September 1st to the 30th, 2021, as National Suicide Prevention Month in Maryland. Thank you.
Thank you so much.
Thank you, guys.
Do you want to stand in the middle?
Maybe you and I.
Yes.
Before we continue, I would like to remind anyone joining us today or viewing online that you are loved, you are valued, and you are not alone. If you're struggling with mental health and or thoughts of suicide, there are people who care and resources available to help. If you have a mental health crisis, you can connect with mental health resources in your area through Maryland 211 by dialing 211 and pressing 1. And you can also call the National Suicide Prevention Lifeline at 800-273-TALK or 800-273-8255. During September, the month of September, the state of Maryland is also recognizing Recovery Month, which seeks to promote and support evidence-based treatment and recovery practices, a strong recovery community, and the dedicated service providers and community members who make recovery of all forms possible. Earlier this month, I attended the National Conference of Oxford House, a network of recovery houses and facilities across the country, and we have a few of them here in Maryland. This was inspiring to see an energized and a very excited group of 1,000 individuals at various stages of their recovery gathered to share stories and support each other. In addition to their testimonials, they rallied around the message of recovery is possible with commitment, community, and other supports in place. In the spirit of Recovery Month, I'd like to acknowledge Barbara Allen, who is a member of this commission and chair of the Howard County Opioid Crisis Community Council. Ms. Allen could not be here in person today. I believe she is watching online, but she is an advocate for improving the response to the opioid crisis in our state. She works to spread awareness of substance use disorder and makes a point to extend compassion and to create community for those struggling, as well as their families and friends. The state of Maryland remains committed to putting every resource we can in place to combat the ongoing opioid epidemic crisis, as well as providing safe and healthy communities. During today's commission meeting, the Maryland Department of Health Deputy Secretary Atif Chaudhry will provide us with insights into his agency's master facilities plan, which includes building 4 new 24-hour crisis centers in each region of Maryland to help address the existing and growing need for crisis services. So with that, I'm going to move to the formal agenda. And first of all, and I will apologize quickly that I took a long time with the introductions today, introductory comments. But I'm going to go through our list just to make sure we record we're officially here. So when I state your name, just state what you do and what your supports are. Senator Eckert.
Good afternoon, Senator Addie Eckert from the Eastern Shore, and I serve on a variety of the Behavioral Health Suicide Commission. I'm a psych nurse by background. I'm on Budget and Tax Committee in the Senate.
Thank you. Senator Hester here? I think she's supposed to be late. She's going to be a little late. Delegate Kelly, I believe, is also going to be a little late. Delegate Young?
Good afternoon. Delegate Karen Lewis Young from Frederick. I serve on the Health and Government Operations Committee, and in the 2022 session, I plan on making mental health issues my priority legislation.
Very good. Thank you. Richard Abbott from the courts is not going to be here today. Tricia Roddy.
Good afternoon.
Good afternoon.
Tricia Roddy, Deputy Director for the Medicaid Program. Our role, of course, is we cover many of the services under behavioral health and reimbursed providers.
Okay, Dr. Jones.
Good afternoon, Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration.
Okay. Lieutenant Colonel Butler.
Lieutenant Colonel Roland Butler, Maryland State Police Field Operations Bureau.
Deputy Director Boninsky.
Hi,
Dr. Linda Banowski. I'm the, I got a promotion, so Director of Mental Health for the
Oh, sorry about that. Director.
Okay. For the Department of Public Safety and Correctional Services. I oversee all the mental health services for the prison system and pretrial.
Thank you very much. And congratulations to you.
Thank you.
Maybe. Okay. Assistant Secretary Trish Rexrod.
Good afternoon. Tiffany Rexroad from the Maryland Department of Human Services.
Okay. Director Barone is, I'm sorry.
Yes, I'm sorry. Commissioner Barain was unable to make it today. I'm Mary Quay, Chief of Life and Health
Oh, okay.
Complaints for the Maryland Insurance Administration.
Thank you very much. Robin Ricard.
Robin Ricard, Executive Director of the Opioid Operational Command Center, and I serve with Dr. Aaliyah Jones on the Maryland Crisis System Work Group.
Okay, and I think Deputy Secretary Mealy is watching on television or on something. Department of Education? Mary Gable? Oh,
I'm sorry.
no, Education?
Yeah. Good afternoon. I'm Mary Gable. I'm Assistant State Superintendent with the Maryland State Department of Education. I work in the Division of Student Support, Academic Enrichment, and Educational Policy. And we support mental health policies and initiatives for our students across Maryland and their families.
Okay, thank you. And I had mentioned Barbara Allen, who is watching along with both the public members, Patricia Matuszewski, and public member Dr. Tripurani.
Good afternoon, Lieutenant Governor. I am a Mid-Atlantic Permanente physician from Kaiser Permanente, and I am a child and adolescent psychiatrist by profession, practicing.
Okay, very good. Ms. Cho.
Hello, I'm Carrie Guthrie Cho, President and CEO of Cornerstone Montgomery, a private nonprofit in the public behavioral health system in Montgomery County.
Okay. Public member Kimberly Watts.
Hi, Kimberly Watts. I am an attorney with the Office of the Public Defender. I'm in our Forensic Mental Health Division.
Okay. And I know we have a public member who works with NAMI.
Yes.
Are you here for her?
Good afternoon, Commissioner Eckwood. She was unable to make it today. My name is Deborah Bennett. I am a mother and a friend and a aunt and sister of individuals who have lived with and struggled with mental health conditions. And I'm really pleased to be here today for such a time as this. While my son is in his 9th crisis since March of last year, and he is a resident of Frederick, currently in the hospital for the 9th time.
Sorry to hear that. Okay. Now, at this point, I need to ask if folks will have to take a vote on the minutes from the previous meeting. Has everybody had a chance to review the minutes? I did suggest that we try to take time to read the minutes. They're really informative, and for me, it brings back a number of the questions and the comments of various people who testified, and it reminds me of things that I need to follow up on as well. Do we have a motion to approve the minutes from the last meeting?
So moved.
Second?
Second.
Okay, all in favor of approval, say aye. Aye. Any nays or questions? Hearing none, they are approved. Okay, we'll go to subcommittee reports. We'll start with the crisis services.
Good evening. So the Maryland Crisis System Work Group continues to be underway through the Behavioral Health Administration and numerous stakeholders. We've been working very closely with our state partners at the Opioid Operational Command Center. For the last 2 years under this commission, the OOCC has led the crisis subcommittee, and at the direction of the Lieutenant Governor and your office, the crisis subcommittee will be assumed under the Maryland Crisis System Work Group, which is chaired by myself. The Behavioral Health Administration is privileged to have the members of the OOCC Crisis Subcommittee join in the Maryland Crisis System Work Group for a unified effort in building the Maryland Crisis System. We had the opportunity since last we met to meet with the New York Family Services League to gain an understanding of the elements of their crisis system. The New York Family Services League has a fully developed crisis system, including a central hotline hub, mobile crisis teams, crisis stabilization centers, and use of technology-driven software, among other services. They shared their experiences, successes, and challenges, which will be beneficial to Maryland. We have reached out to a number of different states to learn what people are doing as we continue to inform best practices here. Our work group has 5 subcommittees, and these are the reports from these subcommittees. Our best practices and standardization subcommittee is developing statewide standards. The best practices standardization subcommittee is working to implement HB 332, or the Mental Health Confidentiality of Mental Records and Emergency Facilities legislation. Each year, the Maryland Department of Health is required to publish a list of emergency facilities that can appropriately receive and provide crisis care to individuals who have been emergently petitioned. HB 332 specifies that comprehensive crisis response centers, crisis stabilization centers, crisis treatment centers, and outpatient mental health centers may be included on the emergency facilities list. The Best Practices Standardization Subcommittee is currently working with stakeholders to develop the program model, structure, and standards to support crisis providers that wish to serve as an emergency facility and to receive emergency petitions. Our Data, Infrastructure, and Dashboard Work Group, this subcommittee is continuing to develop a standardized data collection, reporting, and performance measurement system. The work group is working in concert with the feasibility study for HB 1121, or the Maryland Mental Health and SUD Bed Registry and Referral System. Financial Stability and Sustainability Subcommittee has met with representatives with the Maryland Medicaid Administration, behavioral health providers, and commercial insurance representatives to begin reviewing current and emerging funding opportunities of the Maryland crisis system. In partnership with MMA, we submitted a grant to the Centers for Medicare and Medicaid Services to seek funding for a state planning grant for crisis system development. Our Children, Adolescent, and Young Adult Services Subcommittee, the goal of this group is to have a uniform assessment and early stabilization for children, adolescents, and young adults in crisis. After immediate intervention, a warm handoff is critical with connections to longer-term stabilization services, community-based outpatient, or higher levels of care. The Behavioral Health Administration is working closely with the University of Maryland School of Social Work and School of Psychiatry on data collection, conducting a landscape survey, and working to develop the response model. And lastly, the 988 Integration Subcommittee. In partnership with the 988 Coalition, the Behavioral Health Administration is in the middle of a 6-month planning period, which is funded through SAMHSA. SAMHSA and Vibrant, which is the 988 vendor, plans to launch 988 in July 2022. The Behavioral Health Administration is working on developing a draft plan on the integration of 988 into Maryland's system. This will be reviewed by the Coalition in September, with a final draft plan due to Vibrant and SAMHSA at the end of September. Thank you.
Thank you. Youth and families, I know.
Lieutenant Governor, members of the Commission, and guests. The Youth and Family Subcommittee met yesterday. We were very pleased to hear from the Greater Baltimore Regional Integrated Crisis System, GBRICS, who discussed in detail their 5-year grant from the Health Services Cost Review Commission to partner and collaborate in the community around upfront investments to reduce long-term health care costs. The 4-jurisdiction partnership from Baltimore City, Baltimore County, Carroll County, and here in Howard County will work to reduce unnecessary emergency department and police interaction for people in a behavioral health crisis. This will be accomplished using 24/7 regional crisis hotline with access to real-time coordination, mobile crisis teams, crisis facilities, and post-crisis wraparound support. Additional strategies will include open access service to accommodate same-day walk-in and virtual appointments, community engagement and outreach, and nonprofit multi-stakeholder oversight. We were especially happy to hear that mobile crisis teams will be more than doubling their capacity and dedicating teams to serve children and youth. These teams will include young adult peers and family peers. The members of the Youth and Family Subcommittee were presented an opportunity to respond to a request for public comment regarding involuntary commitment. It's our understanding that that time frame for public comment has since closed. Finally, we began a discussion on the subcommittee's 2021 recommendations for the annual report. Our committee has a strong interest in looking at the bed capacity and service array for individuals dually diagnosed with mental health and developmental disabilities. We plan to discuss these recommendations further at our next meeting, scheduled for November the 8th.
Thank you. Finance and Funding Subcommittee.
Good afternoon, Lieutenant Governor. A couple of updates. So the Finance Subcommittee met on September 7th, and we're scheduled to meet again November 2nd at 1 p.m. 3 updates from the Medicaid perspective, and then I'll turn it over to the Maryland Insurance Administration. So 1, as you know, we have this system of care work group that's a work group between our managed care organizations as well as our behavioral health providers and stakeholders. Those meetings were put on pause, but we are happy to report that we have a meeting scheduled for October 5th at 12 p.m. We have rebranded the name of the work group. We are calling it the System of Care Integration and Optimization Work Group. As we develop the agenda and we get minutes, we'll of course pass it along to you all. Thirdly, I know everyone's eager to hear about our request from CMS, the federal government, to cover institutions for mental diseases for adults between the ages of 21 and 64. We submitted an application to allow Medicaid to cover and reimburse for those services, with the goal of it becoming effective January 1st of 2022. We have not heard back from CMS, so they do have our application. Usually the process, how the process works is they'll submit some questions for us and there'll be some back and forth between us and CMS. Maybe it's good news that we haven't heard anything from them and there's no questions, but obviously as we get, if there's any concerns or issues, we'll pass it along to you all as well. But again, our goal is to implement that by January 1st of 2022. The other exciting news, I don't think we've reported to this group before, under the Federal American Rescue Act, there was a provision in that federal law that allows Medicaid programs to get an additional federal match on certain services from the federal government. We get 10 percentage point increase on our home and community-based services for a specific period of time. So it's from April of 2021 to March of 2022. Again, we get a 10% additional match on those services. The goal and requirement for getting that match is that we have to reinvest those dollars back into our programs. The way that CMS defined home and community-based services is that they included the community behavioral health providers. Our big reinvestment strategy will be increasing provider rates. 75% of the reinvestment dollars will go into provider rates. We've submitted an initial spending plan to CMS. They have yet to provide feedback or approve it. I don't think there are going to be any issues with the rate increase. CMS is a bit backlogged on all the reports, but again, once they approve, we'll begin implementing that rate increase as soon as possible. We have basically until March of 2024 to complete the reinvestment. Right now, we're estimating the behavioral health dollars to be about $112 million that will go into provider rates over that time period. Again, as actual expenditures come in, that number will fluctuate and change, but it's a really exciting opportunity. So we expect to hopefully implement that provider rate increase within the next few months.
Thank you. And then regarding commercial insurance and financing, our two areas of focus are network adequacy and mental health parity and Addiction Equity Act reporting. And on the network adequacy side, we have received the 2021 annual access plans filings. The executive summaries are posted to the MIA website for anyone who's interested. This is the fourth year of filings, and carriers reported broad improvement across the board. In-depth reviews are still ongoing for the 2021 filings or 2020 filings, and will begin on the 2021 filings. And this is to ensure that the improved compliance reported by carriers is actually substantiated by sufficient documentation and valid methodology for measuring their standards. The other area of focus is Mental Health Parity and Addiction Equity Act reporting. By March 1st of 2022, carriers are required to report their compliance to us. And so as part of that, the MIA is required to adopt regulations and standardized templates and instructions by the end of this year. Draft regulations were posted to the MIA website on July 30th. The draft template forms for the reports themselves, along with detailed instructions for completing the forms, were posted on August 6th. The deadline for public comments on the regulations was August 13th, and the deadline for comments on the templates, instructions, and other supporting documents was September 7th. We convened a public hearing on the draft materials on August 30th. After considering the written and oral comments received on the regulations and making appropriate revisions, we are moving forward with the formal proposal in the Maryland Register on the regulations. In the meantime, we will be continuing our work on refining and improving the template forms and instructions, and we will be having another public meeting on those. The goal through all of these efforts is to end up with standardized reporting forms that will ensure consistent, complete, and comprehensive responses are received from carriers with the initial filings of the reports and minimize the amount of follow-up investigation required by the MIA to determine whether the carrier's processes are in compliance.
Thank you. Trish, real quick, so what you were saying about the additional money that's coming in for Medicaid, the provider community, it's going to, they can, I don't quite understand it, and maybe Carrie also can as a provider.
I don't know that I understand.
So they will be able to have, I guess, better pay in terms of what the reimbursement is going to be coming from Medicaid.
Exactly. So it'll be a provider rate increase that'll go into effect probably in the next few months. We're still working out the exact percentage amount. But, you know, it will be sizable for plus higher amount that will go into provider rates, and they'll start seeing them once they're loaded into their systems, and once they start billing for services, they'll see those monies coming directly to them.
Senator?
Trish, I have a question on that. Once those funds roll in, then that kind of raises the provider rate. Is there an expectation and then the state would pick that up and sustain that rate after that time?
DBM has been fully informed of the sustainability issues going forward. So yes, you know, that's one of the reasons why I think CMS gave states an extra 2 years to really complete the reinvestment requirement, so it wasn't so much money within such a short period of time. They allowed us to spread it out till 2024, so it's not like a 20% rate increase. It's more like in the magnitude of 4% or higher, right?
Okay, so if it stays between 4 or 5%, then that's the goal we've been shooting for quite some time, and that would be really helpful on top of what we have. Thank you, Mr.
Okay, thank you. Okay, public safety and justice system report.
Good afternoon. At our last Public Safety and Judicial System Subcommittee on August 10th, we hosted a panel of guest speakers on housing services. We chose this topic as a result of our SIMS Summit in 2020, where housing issues was listed as a top priority across all intercepts. We heard from two presenters, the first of which was Priya, I don't want to kill her name, Shami, the Assistant Director of Evidence-Based Practices, Housing, and Recovery Supports at the Maryland Behavioral Health Administration. She provided an overview of federal, state, and local programs to address housing and behavioral health services, as well as federal grants to support BH-funded housing services. These included HUD's Continuum of Care program, which provides permanent housing and supportive services to individuals with disabilities, as well as families with children in which one adult has a disability. During the pandemic, finding available shelter was especially challenging for individuals leaving the criminal justice system. She suggested that establishing connections between staff and local continuum of care meetings could help resolve delay times and smoothen transitions. We also learned about the Housing First pilot program that serves individuals in Baltimore City, Montgomery County, and Prince George's County. This program provides assistance to individuals with locating, securing, and maintaining permanent housing, with the premise that providing affordable housing first will alleviate other socioeconomic challenges and improve quality of life. Our second speaker was Chelsea Heyman, Housing Policy Director of the Maryland Department of Disabilities. She presented an overview of opportunities and barriers to affordable and accessible housing. These barriers included developmental costs, which exceeded affordable rent rates, limited availability of rent subsidies, zoning laws, a disconnect between housing and service locations, and a lack of funding for rental units. Opportunities to address these include, but are not limited to, passing inclusive zoning laws, providing financial and regulatory incentives to increase accessibility, tracking and matching accessible units with people who need them, and increasing partnerships with local governments to align the public housing stock with low-income housing tax credits. We discussed the potential to utilize American Rescue Plan money to fund some of these opportunities and the role of Public Safety Center of Excellence in these efforts. Our next meeting will be on Tuesday, October 12th at 3 p.m.
Thank you. Just a question for kind of across the board on all of the subcommittees. In the last meeting we had, we talked about workforce and the issues associated with workforce. I didn't know and I guess there was a general request that each of the subcommittees, try to integrate that somewhere, look at workforce as it relates to your different subcommittees. And so just asking the next meeting, maybe there'd be at least some commentary with regard to that. Workforce, particularly in the healthcare industry, is becoming a challenge. It has long been a challenge, as we've known, we've talked about in the mental health and substance use disorder, community behavioral health areas, but also now with in acute care and ICU affected with COVID, and we're entering the flu season. You remember that, the seasonal flu season? There's a concern particularly with the flu season because we really didn't have one last year, so it's kind of, and some of the data, and I know I see Secretary Schrader out there, he could probably talk much more about that, but one of the things that we're seeing with young people in particular on the pediatric side is that the ones who are going into the hospital with COVID, the majority of them have other issues too, other strains of viruses or something else that's there. And so I guess this is a plug. Also to get those vaccines, both seasonal vaccines, seasonal flu, COVID vaccines, and make sure your kids get vaccinated. So just ask that you look at the workforce issues as it relates to the different groups that we have here. Next, we do have a special presentation. I have both Secretary Schrader and Deputy Secretary Chaudhry. I'm not sure which one is doing. I guess it's going to be. Okay, and Dennis, I don't know if you were here when President Hetherington was here, and she made special mention of you and your linkage to the college here. And so it's kind of old home week for all of us.
Yeah, no, I really appreciated her. We did get a chance to chat.
Okay.
So thank you very much. I'm going to, Lieutenant Governor, thank you for having us here today. This is an important presentation. I'm going to tee this up and then have Deputy Secretary Chaudhry give the details. But I think it's important to note that this is a project that we started with the Deputy Secretary about 4 years ago, and we were moving right along, and about 18 months ago we got stopped in our tracks. But we decided this past summer that we were going to get this over the goal line and get it out in the public because we felt it was really important. This is a plan that has got a 20-year horizon that Secretary Chaudhry will take you through that in a minute. But the reason this is so important is that the health department 5 years ago had almost no projects in the capital pipeline. And the only way to get into the capital pipeline is to do a master plan. And so we started down that road. We've been working with the legislature. We submitted the plan to the legislature on September the 2nd as part of a joint chairman's report. And this is actually the first meeting, so thank you for this, the first public meeting where we're having a chance to put this out into the public domain. So step one, we're working on an initial capital proposal with the Department of Budget and Management. And our objective here is to improve the patient care environment and the environment where care is delivered for the providers. And you'll hear from Atif in a minute about what's involved. One of the things that I wanted to make sure was in the plan, and you'll see that as part of it, is that, and given my time having served with the members of the commission over the last few years, is some provisions for 24-hour crisis service facilities. And we had seen a facility up in Bel Air, the Klein Center, which I thought was very impressive, really liked what I saw. And so we've modeled our thinking after that. And we are going to propose 4 sites around the state, Western Maryland, Central Maryland, Eastern Shore, and Southern Maryland. That doesn't mean that'll be the last of it, but we got to get started somewhere. And so that'll be in the plan. That's in the plan, and Atif will talk about that. And I knew that was one of the priorities, and we've been working with Deputy Secretary Jones on her efforts so that we can, really jumpstart this establishment of crisis services. I will say about the plan that's really important. It's very flexible. We were careful not to get locked into a particular location or a particular partnership with, we're trying to be as flexible as possible to establish the partnerships that we're going to need. It's going to be a tremendous amount of work. As I said, this is a 20-year process, and we're just starting down the road of getting this program put together. And the other thing we want to see and we're anticipating is there's going to be a lot of interest in the legislature I'm expecting this session there'll be a lot of hearings. We'll be coming and talking to legislators, getting their input, and we wanted to make sure that what you hear and see today, and by the way, the report's about 150 pages long, so we're not going to delve into that level of detail. But we wanted to make sure that before we got too far along, that the legislature had plenty of opportunity to weigh in and ask questions and make recommendations as we move forward. So I'm going to stop there with the introduction and call up Deputy Secretary Atif Chaudhry, who's worked incredibly hard, deserves all the credit. I'm just introducing him. So go ahead, Atif.
Thank you, Mr. Secretary, Mr. Lieutenant Governor, members of the Commission. Thank you for this opportunity to go over and provide an overview of our master plan. We've made it public about a week and a half ago and have been coordinating ever since, and we're looking to implement, as the Secretary indicated, through our capital budget in the coming years. So MDH, just to give everyone a very quick overview of it, our mission is to promote and improve the health and safety of all Marylanders through disease prevention, access to care, quality management, and community engagement. So as part of our mission, as part of our mission, we have 11 MDH facility campuses located throughout the state. 11 of those are operating facilities, and that's 5 inpatient psychiatric hospitals. We operate 2 residential facilities for individuals with developmental disabilities, and 2 regional institutes for children and adolescents, as well as 2 chronic care hospitals. We also have 3 non-operating facilities that are closed and currently either fully or partially leased. Here's a quick a map and our current facility footprint located throughout. It's a little hard to read, so I'll go over it in a little more detail. So our closed facilities are the Crownsville Hospital Center in Anne Arundel County, the Rica Southern Maryland, which is in Prince George's County, and the Upper Shore Community Mental Health Center in Kent County. For our chronic care hospitals, we have the Deer's Head Hospital Center over in Hagerstown. In Salisbury. We have the Western Maryland Hospital Center in Hagerstown. We have our 2 developmental disabilities facilities. We have the Holly Center in Salisbury and the Potomac Center in Hagerstown. We have the state's only maximum security inpatient psychiatric facility, which is the Clifton T. Perkins Hospital Center, located in Jessup. The Eastern Shore Hospital Center, located on the Eastern Shore. Springfield Hospital Center in Sykesville. Spring Grove Hospital Center in Catonsville, Maryland, and the Thomas B. Finan Center in Cumberland. The 2 regional institutes for children and adolescents, we have one in Baltimore and we have one in Rockville. So, guiding principles for the master plan. As the Secretary indicated, this is a 20-year plan. We wanted to do a comprehensive gap analysis to take a look at what is the department's current needs and what is the department's current capacity to develop services for our current service delivery lines, and look at over the 20-year span what will the need be for these particular services, as well as what other type of services will the department need to provide over a 20-year span. So our guiding principles for the plan were to realign healthcare delivery to support evolving care models and trends, improve patient care environment, implement efficiencies in service through utilization of all appropriate healthcare assets available throughout the state, not just those that are either owned or operated by MDH, and fulfill the requirements associated with the Maryland Medicaid total cost of care model. So the master plan was broken down into 3 phases. It's a 20-year plan. Phase 1 is the first 5 years. Phase 2 is the years 6 through 10, and phase 3 is years 11 through 20. This makes the plan more manageable, more digestible, and from a funding perspective, from the capital budget, it allows us to plan ahead over 20 years as we look to design and develop various facilities and various capital investments. So for phase 1, for the first 5 years of the plan, that includes the divestiture of our non-operating facilities. As indicated, Brownsville Hospital Center, Rica Southern Maryland, and Upper Shore Community Mental Health Center are all currently non-operating facilities. They're still owned by MDH. Brownsville is partially leased. Rica Southern Maryland is fully leased to Prince George's County Public School System, and the Upper Shore Community Mental Health Center is nearly fully leased to Kent County Health Department, where they operate the AF Whitsett Center. The plan also calls for, in Phase 1, to construct 4 new 24-hour crisis centers located in each region of the state. And those crisis centers will be regional. We have not determined a location yet. We did model it off after the Klein Center, as the Secretary indicated, but a lot of room there for further development discussion on what services can be provided, what other aspects, and what regions. And we look to partner with other healthcare providers as well as counties to choose locations and operating models. For strategic partnerships, we'll look to identify and develop strategic partnerships to transition services currently provided at both the Deer's Head Hospital Center as well as the Western Maryland Hospital Center. We're also looking to perform an assessment of the Central Maryland inpatient behavioral health capacity in Central Maryland, and that's going to help inform the plan going forward. So we believe that assessment will help determine the number of beds and the number of and the types of services that are needed in Central Maryland. That'll help inform our plan going forward. As the Secretary indicated, this is an evolving plan. It's not set in stone, and it will shift and will be manageable. So through various initiatives moving forward over the next 20 years. So generally speaking, with master plans, every few years you revisit them and you modify them, and this will be very fluid and it will evolve over time. We'll also look to consolidate the Behavioral Health Administration with the MDH headquarters. So currently the Behavioral Health Administration is located on the grounds of the Spring Grove Hospital Center. That will be consolidated in with MDH headquarters as we relocate to the Baltimore Central Business District fairly soon. Phase 2, years 6 through 10. We were looking to construct 2 new facilities. One is a facility for children. A facility for children is a facility for adolescents that are court involved, that need competency restoration services. And these particular patients are, generally speaking, are not suited for community-based competency restoration services. So they're more, they need more of a structured facility, and they might be an AWOL risk or other reasons that they need to be in a more secure facility. And also construct a new secure evaluation and therapeutic treatment facility. MDH currently operates one at the Potomac Center. This will be a new facility to transition services to this location. And this particular facility is for individuals with developmental disabilities and court involvement. And we will also construct a new replacement hospital building at the Springfield Hospital Center. Springfield Hospital, the replacement building will not only create a new state-of-the-art facility, but will also expand capacity, will expand bed capacity compared to the existing replacement building. Phase 3 of the plan. So years 11 through 20, we will renovate the Holly Center, a major renovation there, and there'll be various community integration plans, including identifying strategic partnerships and integration plans to transition services currently provided at both the Potomac Center and Spring Grove Hospital Center. So that's essentially the master plan in a nutshell, and that gives a very quick overview of sort of the highlights of the 3 phases. Again, an evolving plan. As we continue to move forward, will change over time. We do have a website that we've established here that you can access online. It provides an overview of the plan. It provides a link to download the plan itself, a page for frequently asked questions, as well as an email address. If you have any questions or concerns or comments that you'd like to that you have for the plan, you can submit that to the department. We'll be happy to respond to those.
Thank you. I do have a question about the crisis centers. What type of services will be offered at the anticipated to be offered at the crisis centers?
So initially, Mr. Lieutenant Governor, we were thinking to model it after the Klein Center, so that where we would have a 24/7 call center with also a mobile capability that would be able to go back to the community to respond to people in crisis and bring them to the crisis center. Also a triage area where you'd be able to treat people initially as they come in. I believe there's also a small short-term stay there. They have a number, I believe they have 8 beds at the Klein Center there. They're able to treat for short-term stays as well as an outpatient capacity there to treat on an outpatient basis. So that's initially our initial thoughts there for the crisis center. Again, as we start to evolve the plan and coordinate with partners and local governments, local counties, that may shift a little and change or may expand for our capacity. I know we've been speaking with some partners, and one of the things that has been brought up is ensuring that we've got a very mobile, a very robust mobile capacity to go out into the community. So if we do have a crisis center in a particular region, we're able to service the entire region with that mobile capacity. So that's something we're exploring.
And are you going to divide anything between adolescents and adults?
So that's something we are looking into as well, is how that would look and how that would be treated. Yes.
Senator.
My question.
Yeah, all those are great questions, and those are questions we'll be looking at as we look forward to determine the capacity, the need for adolescents as well as adult. And we work very closely with Dr. Jones and her team to help develop the need as we go forward.
And will the crisis centers try to partner with local hospitals? Is that going to be part of the selection in terms of locations if you have a local partner there?
Yeah, yes, sir. We're looking at that, and that may be something we look to explore. Will partnerships be needed for other operation or site locations, and where should they be located? So as we look to further develop these, I think a lot of those questions will be answered, and we'll be working with local partners as well as counties to determine locations, services, and what type of services are needed where. Depending on the region, certain services may need to be emphasized versus others.
And at a minimum, we'll have to partner with hospitals as a place for people who need long-term hospitalization to go. You have to have a back door.
Yep.
So for people who do need inpatient hospitalization, they will have to go somewhere. This won't be a place where we'll be having long-term, or if someone meets inpatient psychiatric criteria, we will be getting them to an inpatient unit as expeditiously as possible.
What about diversion from EDs to
from
the hospitals to the?
That will be all part of the crisis system.
That's what I thought. Okay.
And that's exactly right. And the ED diversion may, require the facility to be somewhat closer to a healthcare facility or a hospital, just to help facilitate.
As you're developing the physical infrastructure plan, will you also be developing a communications plan so that if beds or treatment aren't available in one region of the state, you'll know in real time where there are beds or treatment facilities available in another part of the state?
Yeah, and are you talking about inpatient behavioral health beds? Are you talking about crisis beds?
All of the above, because it's a problem we've experienced.
Can I just respond to that and say
Absolutely.
that with the bed registry that we will be, that we're mandated to create by legislation, it will include real-time knowledge of where beds are. So yes, it will facilitate timely movement of people through the system.
Thank you.
Mm-hmm.
Great.
Questions for Deputy Secretary Chaudhry?
Great, thank you.
Well, thank you. Thank you very much for that presentation. Okay, we'll move now to the public comments section. And I'll first be asking individuals who haven't testified before when I call you off, and then if there's anyone that we're unable to hear for time, because of time restraints, we'll be happy to accept written testimony that will be posted online. So with that, hold on, I do have my list here. Yolanda Ellis.
Hello.
Good afternoon.
Good afternoon. I'm pretty excited to be here. I sat and listened to all the good plans and stuff you guys are having I wanted to just give just a little brief about my son, and I heard about the crisis centers and things. I live in Charles County, Southern Maryland, and I can honestly say from my heart, I think that Maryland failed us. They didn't listen to the parent. I'm a parent. And when I say that I'm having a crisis and that I need my son removed, of course, they sent me to social services. Social services said they couldn't remove him because there's no place for him to go. I know the question you might ask, well, what was he diagnosed with? Everything above, from bipolar, schizophrenia, all kinds of things. I've had a couple of knives at my throat. I've had a box cut at my throat. And I'm telling you, DSS, I'm telling you that I'm in a crisis. And no one seemed to listen to me. They said they couldn't take him out of my home because there was no place to put him. He's been in 10 different facilities. In Maryland, only 2. The rest of them was in Virginia because I lived in Virginia at the time. We moved here in 2018. So I want, when you guys do all this planning, to actually listen to parents, because my biggest thing is, I don't want to sit at home, because we tend to judge. Sometimes we watch TV and go, the parent should have known that the child was building a bomb or, had a gun. We should have known. But if a parent is crying out to you, please listen. I wrote my governor, and the feedback I got, where after they did their little investigation guest with me, I told them that my son had a crisis at school. The call back was, well, there's going to be some repercussions for the damages of the school. Okay, I prepared for that, but I'm calling you for help. Please guide me to some resources. I wrote my congressman for help. They got in touch with social services, who everybody's been pushing me to, and no response. Is that, well, we can't take him because we don't know what to do with him. We usually take in children that have been abused or mistreated in the home. With his mental stability, we have no place for him to go. He's been in crisis centers for a couple of 2 weeks. I've been threatened with jail time because I said, if I don't get help, I'm not picking him up. I refuse to pick him up. Well, that's abandonment. And you could possibly face jail time. So I made a nice big folder for my husband and said, if I go to jail, this is what you present. Because I don't think nobody in the world is going to put me in jail after all the things I've done and begged and wrote for help. I want you guys to listen to the parents. Crisis centers and stuff are nice, but everybody don't fit in there. Right now, my son is in a program called Go Getters. He's in a home with other mental people. How he got there? He attacked me. He finally attacked me, even though I was crying out, telling people what was going to happen. He busted my windows in my home, destroyed my car, blacked my eye, attacked me, attacked my son. So he's facing perhaps 20 years in prison. As a parent, still a loving parent, I'm still fighting for him because I know there's a mental, because after he came down from the anger, he didn't really remember everything that happened. So jail is not for him. He's an 18-year-old with a 12 or 13-year-old brain or thinking. He's never even rode the bus or gone out with friends or anything because he was always in and out of mental facilities. And after 2 weeks, they sent him home because, oh, he's doing well. No problems. Give him some medication and send him back home. That doesn't work. To the person up here with Department of Education, St. Charles High School is wonderful. I just want to throw it out there. They work with me. They call me at home because they know that I couldn't, when we was in the virtual school, that when I tried to wake him up in the mornings, I couldn't do it, or it would be backlash on me. They worked with him. They worked with me. And please, we need more facilities for these type of children. It's not just to give him a pill and send him home, or because he's fine. Oh, he had 5 great days here. He's fine. No, I'm telling you, it's more than that. Well, Miss Ellis, what can we do for you? Well, we don't know what to do. What can we do for you? I don't know. That's what I'm calling you about. Don't threaten me with jail time, because I'm telling you, if he goes, I'm not going to pick him back up. I'm crying out for help. I'm still crying out for help, even though he's 3 hours away from me. And I got a protection order that he can't come to the house. He won't even know how to ride the bus to my home anyway. But I'm still fighting. So when you do your plans, make sure you have some parent involvement. And every kid don't fit, there's different types of mental disorder. My son, he's just one of those extreme ones. But then there's other kids that have a different type of disorder. So 2 weeks in a facility didn't do him. He's been in facilities for like over a year. That still didn't work. So that's what I wanted to say. Just please have some parent involvement. Listen to us. I don't want my kid to hurt your kid. I don't want him to go to school and bust out windows and throw desks and hurt one of you guys. That's my biggest fear. Even, when they say, no, bring him in. We got to try to get him back in school and meet friends. I'm like, oh, no, please don't do that. Listen to us. Listen to the parent. Because I don't want no one to say, well, she didn't say anything. She didn't. No, I did. I told you he was a danger to himself and others. And Charles County Police Department is wonderful. Even though when I would call and say, well, he's walking down the street with a knife, no one shot him. They came and they talked to him, calmed him down, take him to the hospital, what's the usual routine. He calmed down, he bring him back. Because there was no beds available. I think someone mentioned about short beds. There's no beds available anywhere. So that's all I wanted to say.
Well, thank you. Thank you very much. And a number of our public members are parents and family members, so we do hear, and of course, testimony from individuals like yourself is, informative for us as decisions are made. So, thank you. Deborah Bennett? Oh, that's Deborah Bennett who's...
Go there.
You can testify from right there if you want. I was going to ask you some questions anyway.
Yes, I too am a parent as well, and I am a member of the National Alliance of Mental Illness in Prince George's County for about 10 years. And I found NAMI when I was looking for some type of education on mental health conditions. Oftentimes as parents, we don't understand, we don't want to accept or acknowledge that there's something going on. But when I did, I started looking for resources, and that's when I found the free training that NAMI offered family to family. And I went to Charles County. I live in Prince George's County. I was willing to go to Anne Arundel County to take the training, and made that commute for 12 weeks, 2.5 hours to take a class to learn about mental health conditions. And as a result of that, I am sitting here today. I'm an advocate. And my son is 32 years of age. He was diagnosed as a transitional age youth. 3rd year of college, came home, signs and symptoms. He had a full athletic scholarship, and something happened. As a result, I started looking for resources. And there are a lot of supports in Maryland that a lot of families do not know about. And I also served as a family peer support specialist with NAMI in Prince George's County. because of the different navigation and services that I've found, I have been able to help parlay that into helping parents and the relocation of my son to Frederick, Maryland. Frederick, Maryland has been a wealth of resources for my son. He has a mental health condition and he is severely hard of hearing. And there is a mental health provider in Frederick that provides services for individuals who have a mental health condition who are deaf or hard of hearing. He did really well when he transitioned there in 2018. Did so well that he basically achieved all his goals and he no longer met the requirements for an intensive level service, but they didn't have what they call a step-down service, and there was no residential rehab housing in Frederick at the time for him to go to. So what do we do as parents? We found an apartment. And he was working for the Frederick County School System part-time as a custodian. He had been trained through Maryland Doors, all of those services, and they parlayed him into a job and getting a low-cost car, working in Walkersville. Before that, he caught 2 buses one way, each way to go to work. So he had the support system. When he relocated, the support was gone. He didn't have any peers. He didn't have a family environment. And our family lives in Prince George's County. And as a result of that, when COVID hit, there is even more isolation. And as a result of that, you have nowhere to go, no family, nothing to do. So you oftentimes turn to things of comfort. The substance use came into play. But in spite of that, and that's most recently, since last year, my son has been hospitalized 9 times, and 7 have been within the last 4 months. And within the last 4 months, he has lost his apartment as a result of untreated mental health condition. He goes into the hospital and for short stays. I have been a Kaiser Permanente member my entire life, literally. And I dropped my son from my plan, my federal plan, in August so that he would be able to get Medicare and be able to stay at the Frederick Health Hospital instead of being moved around from hospital to hospital to hospital where there was an opening. He was moved away from his mental health support system. He's out of state, but I can tell you the longest stay he had prior to this one was in Virginia. They had hearings. You're involuntarily committed. There's a hearing. The family members are contacted. They know when the hearing is going to be. We did it virtually. I was able to give testimony as to why my son needed to stay there longer. And they heard that. And as a result, they allowed him to stay. When those hearings don't take place, I have not participated in one hearing in Maryland, not one. Each time he goes into the hospital, he is involuntarily committed. That's what happened. Never a hearing. I've heard, well, the plan for the doctor, the psychiatrist, is to get him stable and to have him discharged before the hearing. First of all, I've never even heard that there was going to be a hearing. I'm inquiring. Sometimes it's often hard to reach the social workers, but if you get a fax number, you can fax in information about their history. Right now, my son is in crisis. He's probably the most stable he's been in a while, and the hospital is really working with him. So we're working to try to get him housing. His behavior, which is a result of a mental health condition, it affects your moods, your thinking, and how you act. So as a result, you're going to be offensive to people. You're going to do things that are uncharacteristic of you, but those things cause you to be able to be blackballed from services because you can no longer now stay in the shelter. How do you get discharged from a shelter? Your behavior is off. So you discharged from the hospital, where are you going? You're now homeless. You're really homeless. And as a result of that, there has to be something seen in between. These short-term stays in the hospital we get you stabilized to a baseline. Each time your brain is getting impacted more and more. So that baseline is no longer a baseline. You're putting them out to say, okay, here's your medication. But all in all, I just want to say that there is a gap. We have to look at what's considered long-term. You know, if we can keep a client in there, patient, long enough to stabilize and connect them to resources that are going to be helpful, then we have made a difference. In Maryland, we do not have the assisted outpatient program. There is no mandatory requirement for them to take medication. However, what I've been told is if he gets involved with a legal charge that goes to a district court, then guess what? He can get associated mental health court, and then through mental health court, he can be mandated to either comply with his medication requirement or he will face those charges. While that is a good program, because guess what? Prince George's County has it, and guess what? My son ended up being associated with it for trespassing, failure to obey. I can't hear, don't have any hearing aids. It worked. And it worked so well because there was NAMI, National Alliance of Mental Illness, me in Prince George's County, working with the mental health provider in Frederick, who was willing to drive my son across county so that he would make those dates. Within a matter of 4 months, he no longer had to report to the mental health court. And the judge was looking forward to meeting him, and she said this, I want to see, this is a demonstration of how the mental health court should work between a mental health provider and then you have the community. However, do our loved ones have to get charged in order to be mandated to take medication? We know they're not compliant. I am firmly believer that if there had been some type of assisted outpatient program, some type of accountability to him, someone assisting him after he got discharged in terms of him being responsible for taking this medication, or there's accountability, he would not have been hospitalized 9 times, because each time he's discharged, guess what? I don't need my long-acting injection. I'm not going to take the pills. I'm homeless. Do I take medication that causes me to be drowsy when I'm just walking around all day? I'm in a shelter certain hours, and in the morning I have to go out. So do I take meds? And the provider told me, he asked her one day, is this the medication going to make me drowsy? She said, no, not this one. So he took it. So long story short, if we have some type of assisted outpatient services that will help our loved ones to remain stable and have some accountability, then I think we would see less use of public dollars with the police force, the mobile crisis, the ACT teams, and then you have parents. I've had to drive to Frederick on numerous occasions to go to court to get emergency petition for my son to get the medical attention for a medical condition because he did not meet the criteria of the police department, probably not the mobile crisis. We had to go on weekends. The mobile crisis wasn't open on the weekends. We literally had to drive twice in one day to try to get him help, and guess what? He still was not taken to the hospital that day. So I am advocating for assisted outpatient services in Maryland. I'm advocating for longer stays in the hospital. Getting someone to baseline is not necessarily baseline. And I feel like, again, listening to the parents, because the lived experience is very, it takes a lot. You know, NAMI has a statistic. We spend 40 hours as caregivers uncompensated a week. Now, just imagine if you have a job. I'm retired, thank God. I am a retired federal, a former federal employee, but I do, you know, still work with NAMI. But again, it takes a lot. I'm a senior. I know I look young, but I'm 62. And it takes a lot, and I'm trying to navigate across counties to do this. And so I have written our governor, and I've gotten responses. You know, I'm going to advocate. I'm going to tap and write and email any and everybody that I can, and I'm doing it from a systemic perspective, not just personal, but it's not just my son. It's other people's sons, it's other people's daughters, it's other people's children. And so again, we're living this, and I'm so grateful for this focus has been for 2 years, and I'm really appreciative of everyone's time and the commitment. As I sat here today, I said there's a lot of resources and people who are vested and really concerned about this area, this topic, this medical condition, and so for that I'm grateful. And so thank you for hearing me. And again, there's some other things that can be done to help our loved ones once they're discharged from a hospital. So thank you.
Well, thank you. And if you've, sat through or were told about some of the previous, reasons that we have the commission, it's because of individuals like you and Ms. Ellis who just spoke. Particularly, the examples I often give is, getting help for an adult family member. It's difficult to get help for a child that's a family member, but it becomes even more so with the adult because our system says that that person is competent when they're not competent. Right. They're not competent to sign a contract. They're not competent to make decisions. But how can they be competent on their own health care? So, a lot of what you raised, we've had discussions about what's called assistant outpatient treatment, but that is usually court order again. And so, it sounds like you're looking for a way that is something that is short of they have to be before the criminal justice system to get this kind of, treatment. But then how do you enforce getting them to take their medication? The assisted outpatient treatment, because it is a court situation and there's a penalty, potential penalty, it's thought that that's an incentive for the person to, continue to take their medication. But I gather part of what you're talking about is just really the service being integrated. That when the person is coming out, and it seems like a lot of times what you were describing is the facility is really treating it as a voluntary, admission and not involuntary. Because when they say, hey, we would like to get them stabilized, that's often, at least my experience with a family member, is that's where they are treating it as voluntary. And then if they're an adult, then they can release that person. Unless you have something signed that says you have to be contacted that they agreed to, they can release that 18, 19, 32-year-old without even informing you because he's an adult, and he's competent. So I understand what you're saying. It's some kind of way that we need that handoff. Carrie and I talked about this probably 8 years ago, before I was even in this position, in terms of the step-down services, that is a gap in our, there are a lot of, it's not just a gap, we have chasms in our system, but that's one of the gaps in our system is the step-down services and kind of the holistic, and so it's how to get there. I was going to ask you some questions as well in terms of what you're planning, so.
There is a program in Baltimore, very experimental, it's a test, outpatient civil commitment program.
I think it ended, didn't it?
Oh, did it?
Yeah, it ended. They had a report.
I was going to suggest that maybe that's something that we put on a future agenda to see if there are any lessons learned from that.
We had them on the agenda, I think it was last year, and there is a report out there, and there's a lot of positives with it. They didn't continue it. Part of it, and if I remember, I have to look at the report again, is that the whole aspect of the court involvement. And I know Evelyn Burton is here, and there were some things where there are people that fall through the gaps on that. But the people who participated in it were very positive about the aspect. So there are components. The way they structured it is not quite the assisted outpatient treatment, because the idea is the person is not in a physical location, but they have to do certain things, and including taking their medication or going to their counseling to continue in this program. But it's basically administered, the typical outpatient treatment program is administered through the courts. So it means you have to have done something, there was some violation to get you in front. Theirs was a little different in Baltimore.
Yeah, it was hospital-based. The referrals came into and then through the hospitals, and if you had to meet certain criteria in terms of the number of hospitalizations that you had to have within a certain period of time that were involuntary, which demonstrated that you had a lack of awareness or lack of insight into your condition, and you would become so ill that you were incapacitated to the point that you needed to be hospitalized. There were limitations around where people geographically where the program could be served. The program was administered through Baltimore City. However, in Baltimore City, like most other hospitals, you have people coming from all over the state. So it limited the number of people who could participate through the program in that particular way. Initially, the program, the criteria for entry were too stringent. Family members couldn't refer people for the program, and so it was expanded over time so that it made it easier for people to gain entry. But it really had a very poor uptake, and I think the biggest reason for failure was that there was a really poor uptake by the providers. The providers had to initiate the process. the inpatient hospital system had to initiate the process. And so, and there was just very little, it was challenging to get people to refer people into the program, even though there were many people who met criteria. I mean, even when the program was operated, the vendor delivering the services was Bon Secours Hospital, which is the hospital the unit that I was overseeing, the behavioral health service line that I was overseeing. So it was our program, and we had a hard time getting our own doctors to refer people into the program who we knew would meet criteria for the program because of lots of different things. For numerous reasons, and those reasons were perpetuated across the system, not unique to our hospital, but the same challenges and the same reasons that other hospitals and other providers didn't refer. And so I think that was one of the bigger challenges that we had, was that there was just a lack of uptake for the service. Yeah, but not to say that the patients who we worked with, like Lieutenant Governor mentioned, we had a lot of success in terms of getting people to be adherent with medications and going to appointments, or if anything, just establishing relationships so that they could eventually be motivated to take medications or go to appointments or let somebody know how they were doing. So I think it was a really, really good program, but there were just some structural challenges that made it not successful.
So maybe it's really taking a look at what worked and what didn't work.
Exactly.
And then seeing, how, like I said, maybe instead of it being hospital-based, being, parent-driven in terms of, but you have to have the professionals to get it into something. So it's where it's housed, but then the referrals have to come from something, someplace. And maybe it's families and physicians to see if they can get more people. And it probably would have to be regional. In that case, it was just the city, and so they were excluding it, or exclusive to city residents.
Right.
Mm-hmm. So then if you make it regional, it can be anyone in the state that can get there. So it's something we can talk about further.
It's worth
Because I was going to ask you, but I'll wait until after we get through the others. Okay, thank you. Thank you, Ms. Bennett.
Thank you.
Janet Edelman.
Good afternoon.
Good afternoon.
My name is Janet Edelman. I'm the chairperson of the Howard County Local Behavioral Health Advisory Board, a longtime member of NAMI, and a family advocate of people living with a mental illness. I'm speaking today as an individual. First, I want to mention some of the things that are going well in Howard County. We are working on implementing a new GBRICS regional crisis system, have just implemented LEAD for jail diversion. The school system has just expanded social workers to 20 additional schools. A new harm reduction program was recently implemented, and we have developed new educational programs. But there is still much left work to do. Some large problems remain, which are under the control of the state of Maryland. Optum's failure to pay Medicaid providers promptly has made it very difficult for providers, and as a result, the people they're serving. I cannot understand how, after all of these years of managed care, the vetting process allowed Optum to be selected if they could not perform, and that the BHA did not seem to have the tools to rectify the situation in a timely fashion. I hope that someone makes sure that this is remedied the next time Maryland bids out for an ASO. I submitted to you a copy of my comments to BHA on the Involuntary Commitment Stakeholders Workgroup report. I want to thank the Commission for studying this issue. While the BHA proposal is an improvement, several weaknesses remain, and I do hope that you look at my written comments. Most concerning is that the proposal does not include psychiatric deterioration as a danger to self. I reviewed comments submitted by Brian Stetton from the Treatment Advocacy Center, and Brian is an expert on this issue, and his comments make a lot of sense to me. My brother has lived with schizophrenia and heard voices for over 50 years. He's an example of how someone who is very ill, but medicated and with support, can live in the community successfully. For those whose illness does not allow them to accept help, Maryland allows them to deteriorate until they are so very ill that they may become homeless, in jail, cycle in and out of hospitals, or be close to death. I believe this is very wrong. And I have a request, if I could put in my 2 cents concerning AOT, just based on what I heard. There are many successful AOT programs across the country. They have set it up so that many people can refer in. It doesn't have to be a provider who, some providers are not in favor of it, and so they fail to use it. It is not a criminal process. It involves the court, but it is a civil commitment process. And we don't have to reinvent the wheel. I think we tried to reinvent the wheel in Baltimore. I don't think it was a successful program because there are so many people in the Baltimore City area who could have benefited from a program like that were not in it for various reasons. There are other programs across the country, New York, California, many others, that have successful programs. You can look at them and implement them. If Baltimore City is not a good place for it, there are other places around Maryland that might be more receptive for a pilot of a true AOT program, which the OCC program was not. I guess.
No, I very much appreciate that. We've talked a lot about AOT, and as we just mentioned, Baltimore City, because they were exclusive to the city, you're not going to get as many people, but there were things that are positive. We're one of the few states that doesn't have an AOT program.
Yeah,
and so it is something that, on this commission, we've talked a lot about it, and hopefully I'll talk to the delegate more about, proposing something in the legislative session, because I do believe that we can make it, like you said, civil commitment. It doesn't have to be the criminal side of it. It still would be court enforced, but you would have a process to make sure that, you're not, just taking people away to get their inheritance or something, locking them up in the Tower of London. But that's not what we're, trying to do. We want to make sure that people who are in trouble get assistance.
Right, and the idea is to help the 2 ladies who testified before me. My heart goes out to them with their situations. The whole idea is to get their children into support and services before they hit the criminal justice system. They're not criminals. In most cases, these people are not criminals. They are very sick and so wind up on the wrong side of the law.
Right.
And so, but then that's a good AOT program, that's what it accomplishes.
Right. Okay. Well, is Dr. Benesky or Director Benesky, you are a doctor, aren't you? Yeah, Dr. Benesky and Director will tell you
I
that
totally agree with you.
she runs basically the largest mental health facility in the state, being at the prison.
I think AOT would have been great for us if we could have referred people once they completed their sentence, instead of trying to certify they don't meet the certification level, that we have to get to a hospital. Because of their crime, they may not be able to get housing. I mean, I'm housing 5,000 people with mental illness. And I don't want to see anybody's child come to me. I'd rather than be in the community. It's sad. Mm-hmm. It's really sad to me. So
thank you for bringing that back up. Thank you very much. Kelly Proctor. Did we lose Kelly Proctor? Evelyn Burton?
Hello, thank you for meeting here. Although before I start, I would like to say I am disappointed with the turnout here.
I am
and
too.
I would hope that you can arrange to continue your virtual call-ins for testimony around the state. It provides so much more access for people. But
Yeah, it's a little more difficult when we're out and about, and so,
Yeah.
you know, that's something we're balancing now, doing it in public, you know, or doing it in Annapolis and then taking the
Right.
testimony virtually, and maybe that's what we go back to. And that's something I think we should talk about as a commission, you know, whether that's the best way, because we have a big auditorium and not a lot of people here.
At any rate, I'm very glad to be here, even though I don't live in Howard County, but I have a relative who has lived here and had difficulties. So my name is Evelyn Burton. I am the Maryland Advocacy Chair of Schizophrenia and Psychosis Action Alliance. That's a new name for us. We were formerly called Schizophrenia and Related Disorders Alliance of America. And from the comments of several organizations to this commission on the most recent draft of the Involuntary Commitment Stakeholders Workgroup report and the report itself, it seems clear to us that this process was viewed by many of these organizations and by the Behavioral Health Administration itself as a political exercise where a compromise recommendation was proposed to satisfy the vocal opponents of involuntary psychiatric hospitalization, rather than recommending an effective and comprehensive solution that actually removes the barriers to treatment for those with the most serious mental illness. As family members and individuals with psychotic illnesses, we are absolutely appalled that the proposed so-called solution does not clarify that danger need not be imminent and continues to deny access to hospital treatment for those experiencing psychiatric deterioration and psychosis. You'll have to excuse me, I get a little out of breath wearing this mask.
You take your time.
The proposed language totally ignores and violates SAMHSA's guidelines for inpatient hospitalization, which the draft report conveniently omits. Specifically, the BHA proposed danger language fails to clarify that the danger need not be imminent, but is rather, quote, reasonably expected, quote, in the foreseeable future, unquote. And no psychiatric deterioration language or psychosis is included as SAMHSA recommends. Instead, those with psychosis are required to deteriorate until they are unable to care for their physical needs and at risk of, quote, bodily harm, serious illness, or death, where bodily harm does not include the brain and illness does not include psychiatric illness. Many of the organizations that offered comments at your last meeting did not accept extensive research showing that untreated psychosis causes actual brain damage. They may accept that, according to SAMHSA, quote, there is evidence for more refractory symptoms and more severe course of illness with increased duration of untreated psychosis. And, quote, early intervention improves function and diminishes impact of illness, unquote. However, they are not willing to enable early treatment for those too ill to agree to voluntary treatment. They expressed unreasonable fears of inappropriate use of a psychiatric deterioration standard, although none of the 24 states with carefully worded language have reported any of this. They are willing to let those with untreated psychosis suffer the terrible consequences, homelessness, incarceration, violence, and death. The Behavioral Health Administration does acknowledge all the research. However, apparently, they don't care enough or are not willing to stand up to the opponents to propose a danger standard that provides true access to treatment. Instead, the report makes unsupported and false excuses. They claim that psychosis itself does not constitute a current danger, make accurate, inaccurate quotes of Supreme Court decisions, ignore other parts of the involuntary standards that require there be no less restrictive available treatment, and make totally unsupported claims about the potential cost to the system rather than the potential savings to the system. BHA ignored all of our comments on the previous draft, so I have little hope they will take them to heart in their final report. Instead, I hope this commission will listen to the families and a recent comment from SAMHSA, quote, "Why aren't we demanding that people with psychotic disorders have access to treatment?" Unquote. The lives of our family members are depending on you and this commission. Thank you. I do want to add one other quick thing if I can. At the last commission meeting, at the end of the meeting, Lieutenant Governor, you asked about how our hospitals are faring compared to the ones in Virginia who had closed their admissions to the emergency rooms. And I think you should be aware that for at least 3, if not 5 years, Maryland hospitals have refused virtually any admissions from emergency rooms because of inadequate number of beds. So we are much worse off in that sense than Virginia, who at least has some hospitals accepting people from emergency rooms. Thank you.
Thank you. Okay. Is anyone here that didn't sign up that was here to testify or wishes to testify? Okay, hearing none. Delegate Young, you talked about that your mission or your objective for this session is to propose legislation with regard to mental illness. Are you willing to talk about what you're considering?
I am, but we all know there's a process.
Yes, it's called sausage making, but yes.
That's right. Well, I had a suicide prevention bill last year, and fundamentally that did 2 things. It said that if you were contemplating suicide, your first visit for treatment, you would not be required to have a copay. That was opposed by the insurance companies. They claimed that they did not have a mechanism to do that, but that came up very late in session. I question that because we've managed to do that with COVID testing and vaccines. So I'm sure there's a protocol out there. Another part of that legislation dealt with ensuring that law enforcement was able to have immediate accessibility to mental health professionals during an encounter with someone who was contemplating suicide. I'm obviously interested in the outpatient civil commitment program. I think Frederick would be a wonderful location. And the one advantage we have is one hospital. And from some of the feedback I've heard so far, that would certainly streamline the process when you have one hospital. And I think for a test to be truly valid, you had an urban setting, so why not look at something with a more rural population? That's another area. A big focus is within our youth. I was at an NCSL, that stands for National Conference of State Legislators, a conference that dealt with mental health in our children. And I was incredibly concerned to hear that emergency departments have had an increase in admissions of children between 5 and 11 by 24%, and 12 and 17, 31% during COVID. And 22% of all families with children in both those age ranges report increased mental health issues during COVID. Now, if 22% are reporting, I'm going to estimate the number is much greater than that, because we all know about the stigma, and some families just won't report or acknowledge. So, you know, what do you do there? There are a number of ideas, more telehealth in schools for mental health treatment, excusable absences that don't differentiate between mental health and physical health, comprehensive school counseling programs and screenings, teacher instruction to teachers to be more trauma-informed. These are just some ideas that have been implemented in other states. They're in conceptual development. I'm in that sausage-making process of reaching out to professionals in the mental health community, getting their input, and then going from there. But also, very important issue, trying to reduce the barriers to treatment, whether it's administrative or facilities. I'm just hearing so many stories about barriers that if there's a way to approach it legislatively, we'll certainly look at that.
Well, that is the mission of this commission, is reducing the barriers to treatment. You know, it's how to get, you know, break down the silos and what is standing in the way of getting treatment. And, you know, be it financial, that's why we have the finance committee.
Right.
If it's crisis services, you know, the youth and family aspects, law enforcement, the assisted outpatient treatment, civil commitment is something that, you know, I think could use a lot of focus. You named a lot of areas, and as we all know, it's multifaceted in terms of the challenge that we have with mental and behavioral health issues. But if there's one area that I think could help, and I think the two ladies talked about that, or where there could be some assistance, is in that, you know, assisted outpatient
Yes.
treatment, and then how do we work on those step-down services as well. Dr. Jones?
I'm sorry, I just wanted to add, I reached out to one of my team member who oversees outpatient civil commitment, AOT, for Maryland. And we still do have the program. It still is an active pilot. We're looking to expand the eligibility criteria, the zip codes that are going to be serviced, streamlining some of the processes with the administrative law judges who have to commit people to the program, and also looking to allow people who are in the state hospitals to participate in the process, because they were previously left out of being able to be included. So it's an iterative process that we're continuing to try to improve.
Now, that is the one that the city is still managing.
That is
correct?
correct. Well, that by the state's legislation. The state's
Yeah.
legislation has the pilot in the city. Yeah.
Senator?
Thank you very much, Lieutenant Governor. I just wanted to add on to what Delegate Young said about the importance of catching these mental behavioral health issues early in school, or, you know, with younger kids. And within the Blueprint for Maryland's Future, there was a 10-page amendment, which I call the Community Partnership Supports Amendment. And that includes, starting in 2023, an additional $25 million to support our schools in mental and behavioral health, and it goes up to $300 million over the subsequent years. Part of that is also to create partnerships between the school systems and the school-based health centers and the providers in the community, because of the shortage of staffing, we're never going to have enough people to get somebody in every school. And the third part of this is to create a consortium which would look at how we could continue to leverage Medicaid, because so many of our children who need help are not enrolled yet in Medicaid. And if we could get assistance through the schools to do that, that's one of the focuses of the study. If anybody wants, more information, I worked on this for like 2 years, and I'd be happy to share.
Thank you. Any closing comments from folks? Anyone? Well, again, thank you, everyone. Thank you, Secretary Schrader and Deputy Secretary Chaudhry for the presentation. Of course, I'd like to thank Howard Community College for hosting us here today. I know that Dr. Hetherington had to go. She had another commitment this evening, but I again want to thank her for hosting us here. It's good to be back in this the auditorium here. I didn't mention it before, but I guess about a little more than 20 years ago, my family and I used to come to worship services actually in this facility. So, like I said, I have a long history with Howard Community College. So, again, thank you. We don't have currently scheduled the next meeting. Well, wait a minute. We do. November 9th is the next meeting. And we'll contact everyone through electronic mail, often called email, to get an idea if we think we should continue the road trips, or maybe it's better that we just meet in Annapolis and go out virtually. Because, I appreciate folks who've traveled to come here, but it seems as though we get a lot more participation when people do come in virtually, and maybe that's a way to go. So we'll survey the commission members to see what the feeling is and make a decision in terms of whether we'll be in Annapolis, where we have the electronics there to be able to go out virtually, or we'll go to another roadshow. So with that, thank you very much, and look forward to communicating with you in another couple of weeks with regard to our next meeting. Thank you.